So hopefully here everybody knows me. I'm Peyton. So this project I started at the beginning of this semester, this fall, in a different class. Is pretty much my capstone project for my BSN degree. Down in Med Obs is kind of the unit that I use to focus my problem on. So it is reducing heart failure readmission rates. Luckily, it still has to do with the heart, so you guys don't have to listen to something boring about infections or things that you guys don't normally deal with. Our hospital, honestly, our rates aren't that terrible compared to other ones, but I'll get into that later. So like I said, this is a part of my capstone project for my BSN degree. I'm focusing on heart failure readmission rates. That is the workplace problem. I have went over a couple different studies that have different interventions that have been found to be effective to help reduce heart failure readmission rates. And then at the end, I'm going to give a recommendation on something that we could change or implement here at IU Health Bloomington to help reduce our heart failure readmission rates. So for the problem statement, patients are readmitted with heart failure exacerbations. Mostly, at least what I saw on the floor, was due to them not following their treatment plan outpatient, mostly due to not following the recommended diet, not going to outpatient provider appointments, and then just not taking their medications like they were prescribed. The general readmission rate for heart failure across the country is 21.3%, and here at our hospital it is 19.5%. So it does show that, I mean, we're doing better than the national average, but I think that there's still a lot of things like nursing care wise that we could improve on that could make that rate even lower. And healthcare is expensive. Having these patients continuously get readmitted for the same thing costs the hospital a lot of money. And if they're readmitted within, I think it's 30 days for the same diagnosis again, the hospital doesn't get paid. So while we're also in a bed shortage, we're also losing money on these patients. So from the patient's perspective, heart failure exacerbations can lead to a lot of negative outcomes. Most of the time they come into the ED due to decreased quality of life that's caused by the symptoms they are facing. Increased shortness of breath, edema are the two main ones that I saw patients come back with. And they're also getting admitted to the hospital frequently, which is very expensive, especially if they don't have insurance or their insurance just isn't great. These patients, if they're getting admitted every couple of months, may have astronomical medical bills that they can't afford. Also, while they're coming to the hospital, they are losing out on time away from work and family, which can just add to more financial stress in their lives. In this section, I'm going to go over 5 different studies that I have found that have helped reduce heart failure readmission rates at different hospitals throughout the world. The first one is titled Impact of an Educational Intervention in Reducing 30-Day Heart Failure Readmission. This study was conducted in the United States on 4 different progressive care units within one hospital. It included 165 nurses that were working on those PCU units. So the purpose of this study was to assess if having the nurses go to an educational course regarding heart failure management and the use of the teach-back method would help reduce heart failure readmission rates. So then when nurses were educating their heart failure patients, they used the teach-back method and then other topics that were discussed for heart failure management during their course. And the results from this study showed that their heart failure rates decreased at this hospital from 19.53% to 15.35%. The second study is titled Relationship Between Early Physician Follow-Up and 30-Day Readmission After Acute Myocardial Infarction and Heart Failure. This study was conducted in Taiwan throughout multiple different hospitals. The purpose was to see if having patients follow up with a physician early after discharge would help reduce their readmission rates. And they weren't too focused. They were trying to see if they had the patient follow up with the exact same doctor that they had been seeing during their hospital stay, if that was any correlation to their rates, but it didn't really work out that well. So they pretty much broadened their scope to have them follow up within 7 days after discharge with any physician. and it helped show that readmission rates were decreased with a p-value of 0.001, and that result showed that it was statistically significant. For the third study, it is titled Loop Diuretic Prescription and 30-Day Outcomes in Older Patients with Heart Failure. The study was also conducted in the United States and included quite a few hospitals, 259 to be exact, and a lot of patients. So there was like 7,936 were the total group of patients used in the study. 5,568 of those were a part of the intervention group, and 2,368 were a part of the control group. So the purpose of this study was to see if patients were admitted to the hospital that were not previously taking diuretics before they came in, and then at discharge they were started on a loop diuretic, to assess if that would help improve their outcomes and reduce readmission rates. So the results of this showed that patients who were newly prescribed a loop diuretic had decreased rates of readmission to heart failure with a p-value of 0.037, which was also statistically significant. The fourth study is titled Relationship Between Nutritional Status and Clinical and Biochemical Parameters in Hospitalized Patients with Heart Failure with Reduced Ejection Fraction with a 1-year full follow-up. The study did take place in Poland, and it looked at patients that were on an inpatient cardiac unit, and it included 120 patients. So the purpose of this assessment was to look at the link between a patient's nutrition status and heart failure readmission rates. There wasn't really a specific intervention that they used. They did use a certain nutritional assessment during the patient's admission. It's called like the mini nutrition assessment, which was pretty much just a basic questionnaire to ask the patients about what their normal diet is, looked at their BMI and different things. So the results from this study showed that patients who are malnourished were more likely to be readmitted at 82% compared to patients with a normal nutritional status at 30%. And this was a p-value of 0.004, which is statistically significant. The last study that I looked at is titled Self-Care Educational Intervention to Reduce Hospitalizations and Heart Failure, a randomized controlled trial. The study was conducted in Australia and included a total of 200 patients. 100 of those patients were a part of their intervention group, and the other 100 were a part of the control group. The purpose of this study really was to see if having patients learn a little bit more about their disease and self-management activities that they could do at home would help decrease heart failure readmission rates. The intervention included having patients watch an educational DVD by themselves in their room, and then after the DVD was done, the nurse went in, had a conversation with the patient, assessed if they understood what was taught to them during the DVD. If they had any questions, the nurse would follow up and try to answer them the best they could. At the 1 year post-intervention, the intervention group had a decreased risk of readmission by 30% compared to the control group. And that was a p-value of 0.05, which is also statistically significant. So for my PICO statement for this project, PICO stands for Population, Intervention, Comparison, and Outcomes. The main population that I'm focusing on with this workplace problem is adult patients who are admitted with heart failure. An intervention that I have found that could help improve this problem here at our hospital would pretty much be creating a standardized heart failure protocol for nurses or staff in general to follow while providing care for these patients. For comparison, we do have one protocol that I found on our policies and procedures website, but it pretty much only relates to the advanced heart care center nurses calling the patients, I think like within a week of being discharged with a heart failure diagnosis, to see if they already have a follow-up appointment at that facility or if they need to get a referral and get them scheduled for an appointment. So nothing really is out there that provides information on what the nurses should be educating patients about while they're admitted for heart failure, or just like a set standard outline for people to follow. The hope is that a new intervention of a formalized heart failure protocol would help create the outcome of improving patients with heart failures, disease self-management while they're at home, which in turn would decrease our readmission rates. So, like I was kind of saying earlier, our current practice that's contributing to the problem, we don't have anything like set in stone or a standard of what kind of care we should be providing to heart failure patients. Of course, when they come in, the physicians like update their meds, put them, diurese them, give them more Lasix, things like that. But while I was working on the floor, I noticed a lot of nurses rushing through education with patients, which is, kind of understandable. We're in a staffing shortage. You have a bunch of patients on a med-surg floor, and you feel like you don't have time to do anything really. But I think if patients were provided with a little bit more education on the whys and the reasonings behind why their diet kind of sucks, why they can't have sodium, why they're having decreased fluid intake, like they're on a fluid restriction. If they understood more of the reasoning behind why the doctor was ordering these different things for their treatment plan, I think maybe they'd be a little bit more inclined to follow their treatment plan while they're at home to help prevent further hospitalizations in the future. So this is super hard for you guys to see now because I thought I was going to be able to do it up on the TV, but this is just the current heart failure protocol that I found. It has a couple of different sections that talks about if a patient's discharged from an inpatient unit compared to like the ED and when the follow-up phone calls are, but it really doesn't provide any information for like actual inpatient nurses here. So suggestion for improvement, like I was saying earlier, create a formalized heart failure protocol. It could cover using things such as the teach-back method to use while nurses are providing patient education, educating the patient about the diet that the physician has ordered for them, exercise that they could be doing while at home, as well as medication education, especially if there's any changes to their medication list while they're here in the hospital. And also completing more thorough nutritional assessments on admission. Our admission questionnaire, I think for nutrition, has 2 questions, 2 or 3, and it asks if the patient knows if they've lost any weight in the last 3 months. And then the other thing is, how are you eating? So it's just not very thorough. It's easy for the patients to just whiz through the answers. I think if we did something a little bit more in depth, we could assess if a patient needs to have a consult with a dietitian while they're admitted as well. To help educate staff about the new protocol, we could use our ELMs, as well as unit educators could be a good resource. And then to measure the results of if the intervention is even effective, we could measure the heart failure readmission rates at 3, 6, and 12 months post-intervention, and then compare those rates to the year prior to see if there's any difference. This is a very basic overview of the PDSA cycle, and I'm going to go a little bit more into detail on this slide about how we could use that to implement this intervention. So for the plan section of this process, it would involve creating the new protocol and the ELMs to provide staff with education, and also deciding when the whole protocol would be released to the facility. The do section would be implementing the new protocol, seeing if there's any barriers causing the protocol to not be followed by staff. And then for the study section, heart failure readmission rates will be assessed at the 3, 6, and 12 month mark to see if there's any changes. If the staff are having any barriers to using the protocol, then that can also be assessed, and then changes can be made, such as like more staff education if unit educators need to be one-on-one with some nurses to provide more thorough education to help them understand the reasoning behind the change. And then in the last section, ACT, if there are any other issues, I think it would kind of lean on unit managers and educators to kind of assess if their staff is following the protocol or not. And then if they realize that pretty much the whole unit isn't doing it, it would be time for like more of a like an in-person meeting so they can talk to staff about the reasoning behind why the practice change is needed. Okay, so for this post-presentation discussion, I pretty much have to read these questions and see if you guys have any feedback. I have answers for all of them from what I think my perspective is on it, but we're supposed to kind of see if our peers think it would be possible even to use in our facility. So first question, is this intervention appropriate or feasible for our hospital? See if I have any thoughts.
Sure, yes.
Especially with elms, yeah.
Yeah. So my answer I agree. I think it would be feasible, especially since it relates to patient education mostly. That's already a part of the nurse's job. It just provides more of a outline for nurses to really hit the biggest parts of the picture of educating a patient with heart failure to make sure that's being done while they're admitted.
Especially for new nurses too.
Yeah, that was kind of my thought coming with it. I don't have a lot of experience as a nurse. Obviously, I've been a nurse for a year, but there were quite a few new hires that we would get, and at that point, you know all the things, but you don't know how to put it into your practice. So, second question: how will the intervention positively or negatively impact the nurse's obligation to provide holistic, culturally sensitive, and patient-centered care?
I think positively, it's going to affect the nurse knowing that she did a complete job, more thorough job, and helping the patient to understand. But negatively, it could also form some frustration in the fact that they don't have the time to be able to implement what they feel is appropriate and give to those patients.
Yeah, I agree. I think it could also help positively impact our patients if nurses do have the time to provide more thorough education. They could leave the hospital having a better knowledge of their disease as a whole and how they can manage it at home.
I think it would be great if there was something ongoing. If they got something at discharge and there was information that was presented to them and maybe it was, this is what we go over this time.
Very basic.
Take this with you when you go to the doctor's office.
Yeah.
And then they take it with them to the doctor's office. And that same thing is reiterated again.
Mm-hmm.
And then also making sure that they do like cardiac rehab and things like that.
Yeah.
Because I know cardiac rehab, I don't know about here, but my experience with cardiac rehab is that they do a lot of education there as well too.
I think that would be the most beneficial because you think like if they're going to like the Advanced Heart Care Center here that they have, the providers and nurses have a lot of more one-on-one time with the patient.
And not only that, but the more times the patient hears it, the more it'll sink in.
Yeah.
Because they're overwhelmed when they're here.
Yeah.
They're so overwhelmed with so much information. They get a folder or whatever and all these papers to go over, and it's too much for them.
Yeah.
And then to be able to go home and kind of look it over, and then to take it with their doctor and reiterate it again and again and again.
Yeah.
It sinks in more.
Especially if it's a new diagnosis too.
Sure.
Yeah.
Sure.
That would be very beneficial, I think.
Being consistent and having it uniform across all levels
Mm-hmm.
would be amazing.
Third question, what are the legal and ethical implications for nurses who will be implementing the intervention? This one's kind of hard.
I think having the protocols behind you.
Right.
You have to have a protocol to fall back on, especially if you're going to be titrating medications, if you're going to be adjusting diuretics based on weight gain and things like that. You have to have legally those.
Yeah. My professor also brought up a good point, like legally, hospital-wise, if this was implemented, if nurses aren't following the protocol, like what is the hospital gonna do, like repercussion-wise? Like are they gonna have like so many strikes with, your unit managers or educators looking at to see if nurses are actually following the protocol? Are they then gonna be brought into the office and discussed with about not following it, and then like what happens when they continue to do it, kind of thing? So that would be something to think about as well. If it was a protocol, it would be kind of more set in stone that people needed to follow it. Fourth question, how will implementing the intervention positively or negatively impact the interprofessional team?
I think like Angie was saying, if it was like a building block, right? So if nurses give like the basic understanding and go over like the basics first, and if they take it to their doctor, doctor's appointment, the doctor can maybe go over the basics again to hear it a second time, but then maybe also add some other things about, kind of the doctor perspective, things that they're worried about. So that will affect all members of the healthcare team.
Yeah, I think so too. I think it would help provide a positive impact if it was, like you were saying, like a building block, like it continues to go through, because doctors would probably have a better time educating their patients on small things, because most of the time, the doctors are in the room for, what, 5 minutes, you know,
They don't
here.
have the time to do that.
They don't have the time to do anything. So if the patient already comes in with a general understanding of, I'm taking this med for this reason, and I'm following this diet for this reason, whenever the doctor gives a short snippet of, oh, I'm gonna increase your dose because you're retaining fluid, they would be like, oh, like I already understood, that's why I was on the medication in the first place. So. And then, what are the barriers to implementing the intervention, and how could these be overcome?
Getting everyone on board,
Yeah. I think-
getting the actual nurses like say, okay, this is how we're gonna start it, forming those committees, forming those protocols. I think that's like getting it started would be the biggest
And I think
hurdle.
working with the other members of the interprofessional team to discuss, okay, what should be actually included in the protocol? What's most important for the patient to know? Kind of setting that standard.
I agree.
There's a financial
there is too,
implement
yeah.
as well, because one of the barriers financially is that you're not getting reimbursement for readmissions. And I think there's also some financial burden on seeing them in the outpatient clinic as well.
Yeah.
You're paying for mid-levels or doctors or whatever to do something to prevent a readmission, and it's not cost effective except for on the back end.
Yeah.
You know, you're, from an administrative standpoint, you're paying for all these healthcare workers to be doing things to prevent stuff, to prevent losing money, not making money.
Yep.
So we're not reaping the benefits except for on the backside,
Right.
and that's hard from an administrative standpoint for a lot of administrations to understand.
Same. Yeah. Okay. Last question. Who are advocates to involve in implementing the intervention? Why would these people be considered advocates? From my perspective, I kind of just discussed like unit educators would be like the very small, like tip of the iceberg, like be
Yeah.
super easy. They're very accessible to all the floor nurses, especially in the beginning stages of any change. It's hard for everybody to remember every little thing that you read on a protocol or you see in your ELMs. So if they had a quick question, especially during day shift, they could go to the unit educator. The educator could walk them through the different steps of the process, you know, in real time and help answer any quick questions they may have. Also, it would just depend on the hospital. If, say, our readmission rates were higher than what they were, higher than the national average, if they administratively were losing a bunch of money on the readmissions, they would probably be more inclined to start making changes, you know, educate the nurses a little bit more, put more protocols in place to help kind of save their own butts.
I think it needs to be over the spectrum though. I think
Yeah.
it's not just in the acute care setting.
Yeah.
It's in the offices, in the clinics, in heart failure clinics, in
Yeah.
cardiac rehab, in all those things.
Everyone's
to reiterate it,
responsible
you know.
for caring for heart failure patients,
Yeah.
whether it's in the hospital or
I think that's a
outpatient
big
setting.
thing
Home
too.
health even. you
Yeah,
know,
exactly.
That's another thing.
A lot of the
including
patients-
home health if applicable.
A lot of the patients I cared for
Or family
like,
members too.
never went to their outpatient. Like here, that a few that I had cared for frequently were not going to outpatient provider appointments at all. And then they, at like about every 3 months, like clockwork, they'd end up back on the floor.
Yeah.
And it's just like, well, that
Well, and
means,
some of this is, you know, we're discussing like non-compliance, but some of this is just in stage as well.
yeah,
It's just a progression of the
it's
illness
gotten worse.
that they try to be compliant and it just doesn't
Yeah.
matter because of it, you know,
Yeah,
the disease itself progressing.
that's true. Does anybody else have any other questions? I love the references.